Good evening, everyone, and welcome virtually to St. Mary's College, located in Notre Dame, Indiana. My name is Arlene Montevecchio, and I'm the director of the Center for Spirituality here at the college. St. Mary's was founded in 1844 by the Sisters of the Holy Cross, and the center was also generously sponsored by them in 1984. The Center for Spirituality offers programs at the intersection of faith and reason, with special attention to women's experience. I would now like to invite Emily Cypus Butler, Associate Director of the Center for Spirituality, to read the St. Mary's College Land Acknowledgement Statement.
We wish to acknowledge and honor the Native people and their traditional homelands on which we stand. We particularly recognize the Pokagon Band of Potawatomi and the Miami, who have been utilizing this land and its resources for many years and continue to do so today. With deep gratitude, we acknowledge the Native people and their culture within our community, as well as acknowledging the land upon which we gather, pray, learn, and work.
Thank you, Emily. The format for tonight's event is a formal lecture followed by question and answer. We will open the chat box immediately upon the lecture beginning, and you can pose questions privately to the moderators. We will ask as many questions as we can as time allows. It is now my privilege to introduce Dr. M Therese Lysott. Dr. Lysott is a professor at the Neiswanger Institute for Bioethics and Healthcare Leadership at Loyola University Chicago Stritch School of Medicine. Dr. Lysott holds an MA in theology from the University of Notre Dame and a Ph.D. in theological ethics from Duke University. She is director of the graduate program in healthcare mission leadership and has served as associate dean of the Institute for Pastoral Studies at Loyola. Dr. Lysott is the author or co-author of Catholic Bioethics and Social Justice, Caritas and Communion, On Moral Medicine, and Gathered for the Journey. She was recently appointed to the Pontifical Academy for Life. Dr. Lysott, welcome to St. Mary's College.
Thank you. Let me get my slides up and then we will be on our way. All right, there we go. Thank you, Arlene, for the welcome. It's great to be kind of back at St. Mary's. As you said, I did my MA at Notre Dame and I spent a lot of time over at St. Mary's, mostly studying, but it was a really nice place to escape and dwell and learn and be. So it's nice to be great to be back in person, but it's nice to be back virtually. I'm really grateful for the invitation to join this lecture series. I even posted on Twitter this week that I'm sort of stunned. I'm listed on the same roster as two people who really have shaped my life and work, Paul Farmer and Corey Mitchell, who both are coming up in March. So I want to encourage everyone who is here tonight to sign up for both of those lectures because they are both amazing thinkers and workers and people in a whole variety of ways. I'm also really grateful to be having this conversation under the auspices of the Center for Spirituality at St. Mary's. You provide a space to talk about these issues that we'll be dealing with over this spring, from global health and the pandemic to health disparities. And tonight we're going to focus a little bit more carefully on the question of COVID vaccines, but to do so from a perspective of theology and faith and spirituality. This is my passion, so I'm really glad to be in a space where we can look at these issues from a perspective of faith and spirituality and theology. I take my title tonight, I'm gonna move you guys up there. I take my title tonight from a third key person who has shaped my life and work, Pope Francis. In his most recent book, Let Us Dream, that I would recommend to everyone here as part of your Lenten reading, he makes this observation. The basic rule of a crisis is that you don't come out of it the same. If you get through it, you come out of it better or worse, but never the same. This is the moment to dream big, to rethink our priorities. God asks us to dare to create something new. We cannot return to the false securities of the political and economic systems we had before the crisis. We need a politics that can integrate and dialogue with the poor, the excluded, and the vulnerable, that gives people a say in the decisions that impact their lives. We need to slow down, take stock, and design better ways of living together on this earth. We have been and remain in a crisis, that's for sure. What is more, the pandemic has brought into stark relief a series of underlying long-term crises, which reveal how our pre-COVID political and economic systems have relentlessly exacerbated inequalities in income, wealth, housing, work, life, and more, both within our local communities and across the globe. Before March 2020, these inequalities and disparities were invisible to so many. But as the pandemic unfolded, we watched as wealthy countries and individuals hoarded PPE and ventilators. We saw health systems across the globe decimated by decades of fiscal austerity, leaving them overwhelmed with sick and dying patients. We saw the elderly across the globe dying in horrifying numbers. We saw the devastating impact of the pandemic on communities of color, which in part fueled the outcry for racial justice spurred by George Floyd's murder. I will admit, I am ever an optimist. So when I read this passage last December during Lent, I was really hopeful, actually, that as the newly available vaccines were finally approved and being rolled out, that we had learned from the crises of 2020 and that a different set of priorities would shape vaccine distribution. Oops. But today, as we mark the beginning of Lent, it looks as though the rollout of the COVID-19 vaccines is pretty much working out to be business as usual. As the story from yesterday's New York Times reports, zip code data reveals that the share of New York City residents who are fully vaccinated in some of the wealthier Upper West and East Side zip codes, where high proportions of white residents live, reaches up to 8 times the rate in parts of predominantly Black neighborhoods like East New York. This is a pattern that, as we will see later, is being replicated across the country, with the vaccine flowing disproportionately toward areas with wealthy and white residents, even though low-income communities of color remain the hardest hit by the virus. So it is good that we are in Lent, for there is much for which we need to repent. Pope Francis calls us to rethink our priorities, rethink the priorities that shaped our pre-COVID world. Tonight, I would like to provide a snapshot of what that rethinking might look like. Behind my remarks lies my recently published book, Catholic Bioethics and Social Justice. In this book, we argue that Catholic bioethics needs to be reoriented and revivified using the lens of Catholic social thought. Such a lens is crucial for enabling us, whether we're Catholics or bioethicists or people who work in healthcare, or simply people who care about the moral dimensions of medicine and healthcare, to begin to adequately understand both the complexity of standard issues encountered in the clinical setting, issues such as the way that racial differences affect end-of-life decision-making, or social dimensions of genetic technologies, as well as to expand the scope of what counts as crucial ethical issues related to the practice of medicine and healthcare. Issues that, even though you can probably not read the very small print there from the table of contents of our book, issues such as gun violence, human trafficking, unions, the diversity of a hospital staff, the environmental impact of healthcare practices, just to name a few. Little did we imagine when we wrote the book that within a year, we would have such a profound case study of our main point. Suddenly, we all found ourselves collectively immersed in what will likely prove to be the most profound healthcare issue of our lives. The COVID-19 pandemic ripped from our eyes the veil that hid from most of us the deeply social dimensions of contemporary medicine, and as if through a megaphone, shouted for the need to rethink our priorities, both in bioethics and medicine, so that we can name, address, and resolve the acute moral fractures that plague healthcare in the US and globally. And not only were we faced with a novel pathogen with a frightening array of clinical courses, with essentially no effective treatment that spread like wildfire across the globe, we were suddenly beset by a barrage of ethical dilemmas and morally fraught realities. In my remarks tonight, I would like to provide an overview of those dilemmas, the ones that Catholic bioethics engaged, but more importantly, to take an honest look at how the standard tools of Catholic bioethics, what we might call bioethics business as usual, rendered the field incapable of addressing or sometimes even seeing a whole array of critically important issues and questions. So in the first part of our time tonight, I will consider the pandemic itself very quickly, a sort of bioethics speed dating approach. And then I will turn to a more extended focus on the most recent issue, that of the COVID-19 vaccines. So first, the pandemic as a whole. As the pandemic emerged last January, bioethics, both Catholic and secular, moved into high gear. Hospital ethics committees and emergency crisis management teams were mobilized. Pandemic protocols that had been developed with the outbreak of SARS in 2002 and refined during the H1N1 epidemic in 2009 were unearthed, dusted off, and implemented. With few exceptions, the questions posed in the early phases of the pandemic concerned issues and decisions to be made within the clinical setting, and almost all of them were traditional questions regarding the allocation of scarce resources under triage conditions or end-of-life treatment. For example, bioethicists wrestled with questions like, how should the few effective treatments, including ventilators and ECMO and later possibly plasma from patients who had had COVID, how should this be allocated to patients? Should we use SOFA scores, as this particular algorithm does? What about comorbidities and other risk factors? How about age, right? How do we make these allocation decisions? How should we allocate scarce protective equipment among frontline healthcare workers, which in many ways was a new question in the United States? Can we override patients' advanced directives? That had always been taboo, but now it was a live question. Given the high risk of contagion, were healthcare personnel obligated to resuscitate infected patients who coded? Right? These were the kinds of questions that bioethicists were asking. Here, the traditional principles of bioethics, autonomy, beneficence, non-maleficence, justice, and utility, for those of you familiar with bioethics, were used to develop allocation schemes that would maximize the benefit of medical treatment to individuals and society, while treating patients and staff as fairly as possible. Interestingly, very quickly, shifts in the principles emerged, with the principle of utility taking precedence, while autonomy uncustomarily took a back seat. For example, some bioethicists floated the idea of a universal DNR, proposing to categorically decide in advance that COVID patients would simply not be resuscitated if they coded. An idea which was quickly shot down by Catholics and others as discriminatory, counter to human dignity, and bad medical practice. Here, bioethics did what it had long been prepared to do, and it did it pretty well. But what quickly became clear was that the scope of the critical questions raised by the pandemic greatly transcended decisions in the hospital and the ICU, and that the principles of bioethics were not sufficient to even begin to address these critical issues. In almost an instant, the location of bioethics was reconfigured. We suddenly saw via this map that I'm sure every one of you looked up for days on end last summer, that the ICU at St. Joseph Medical Center there in South Bend is intimately connected to Wuhan, China, and Bergamo, Italy, and Lima, Peru, and more. We also saw that the clinical setting could not be decoupled from local geographies, as the pandemic unmasked the scope of systemic racism as a moral blight upon American medicine. Deeply troubling disparities in infection and mortality within African American, Latinx, and Native American communities began to emerge as early as April. In November 2020, researchers from Stanford and Duke found that during the first 6 months of the pandemic, as you see here, Black and Hispanic people, who comprise 13.5% and 18.5% of the US population respectively, made up 58% of all patients hospitalized for COVID-19 and 53% of those who died from the disease. These figures counted only inpatient deaths and only considered data prior to the much larger surges in infection and death in the second half of 2020 and into 2021. An important finding from this study was that these disparities were not rooted, as some hypothesized, in biological differences. The researchers did not find any racial or ethnic differences in mortality rates among people who were hospitalized with the disease. Rather, they found that a disproportionate number of Black and Hispanic people became sick enough to require hospitalization and therefore made up 53% of inpatient deaths. So what was driving these extraordinary disparities in infection and severity? Two things. First, existing racial disparities in the rates of chronic underlying medical conditions, such as diabetes, high blood pressure, cardiovascular disease, and obesity, caused by the social determinants of health, was a major factor. But second, these were then complicated by socioeconomic factors specific to the pandemic itself, including higher rates of essential service work, inability to work from home, crowded living conditions, lack of access to PPE, and higher rates of uninsurance and financial insecurity. The researchers also noted, very importantly, that these variations in mortality were explained more by site of care, like the hospital people went to, rather than by race or ethnicity, leading to questions about the ways in which, quote, minority serving hospitals or hospitals in poor communities are resourced. In other words, what was happening in the ICU was a direct result of broader, long-standing social and economic realities. These outcomes were not actually new. We have had all kinds of data on all kinds of health disparities for decades, but suddenly they became undeniably visible in a context where everyone was affected by the same disease. We also saw that our economic infrastructure was not only disproportionately killing people of color, it was also killing healthcare delivery. Decades of neoliberal economics had reduced public funding of healthcare, while hospital management had focused on cutting personnel, increasing efficiencies, and outsourcing services to other countries in order to maximize profit. This led to the bizarre paradox that as hospitals and health systems were being swamped with COVID patients, they were losing money and had to lay off workers. In June, the American Hospital Association projected that the total losses for the nation's hospitals and health systems would be at least $323 billion in 2020. As a result, between February and August, the US health sector laid off approximately 800,000 people. Were these among the 14.6 million Americans who are estimated to have lost their health insurance in the middle of a pandemic due to job loss? These same forces had long been decimating healthcare delivery in rural America as well, which now found itself bereft of hospital beds and healthcare personnel. These factors equally contributed to the devastating mortality in long-term care facilities. Not only were many facilities, especially for-profit facilities, woefully understaffed with back-breaking patient loads per caregiver, who often had no PPE, it became clear that many caregivers in these facilities were contract or part-time employees required to work for multiple facilities, unknowingly spreading the virus from facility to facility to facility. And of course, many of these caregivers were women of color with no insurance, sick leave, or other benefits. We could keep going with this list of issues. We haven't even talked about gender, the elderly, the morbidity and mortality secondary to loneliness, isolation, and job loss due to social distancing and the economic shutdown, the exacerbation of mental health issues from these same factors across the country, the extraordinary trauma and moral distress experienced by the frontline healthcare workers who were not fired or laid off, the exponentially higher toll, sometimes called the black tax, on healthcare workers of color under these conditions, the unfathomable rejection of science and simple practices like mask wearing. All of these are the result of long developing social factors that intersect clinical realities. And we could talk about all of these, but instead, I want to spend the rest of the time tonight displaying how this need to expand Catholic bioethics via the lens of the Catholic social tradition is illuminated by the most recent pandemic issue, the COVID-19 vaccines. The Catholic social tradition calls us to analyze the COVID-19 vaccines through a lens shaped not solely by principles of autonomy or utility, or even, as we shall see, moral cooperation, but by commitments to solidarity, subsidiarity, participation, preferential option for the poor and vulnerable, with rigorous attention to politics and economics, and even perhaps theology, as modeled by Leo XIII in Rerum Novarum. And if anyone doesn't think that politics has to do with medical ethics, all we have to do is take a look right here at the name of the Russian vaccine. Now, perhaps many people in the audience are too young to know what Sputnik means, but for the rest of us, this makes it all patently clear. What is more, at its heart, the Catholic social tradition is not just about principles, it's about social location. It calls us to change the place from which we do bioethics. Returning for a moment to Let Us Dream, Pope Francis states, as it says here, you have to go to the edges of existence if you want to see the world as it is. I've always thought that the world looks clearer from the periphery. You have to make for the margins to find a new future. The Catholic social tradition presses us to go to the peripheries, to move the table, in the language of liberation theologians, to move it out of the hospital, out of the clinic, in order to listen to the people who live and work on the margins of our society. It is only from there that we can begin to authentically see and understand the practical and moral realities relevant to our practice of medicine and healthcare. So if we were to view the COVID-19 vaccines from the peripheries using the lens of Catholic social tradition, what moral and ethical questions might emerge? That is the question for our remaining time. But first, bioethics as usual. In early November, Pfizer announced that it was ready to release data from its phase 3 clinical trial with a novel mRNA vaccine. And what good news it was when the data was released. 95% effective. In late December, vaccinations began. It was a moment of hope in a dark year. Just as the bioethics infrastructure had geared up for triage of PPE and ventilators in February, It now shifted into action to prioritize candidates for what for many months would be scarce doses of vaccines. As before, recommendations were clearly shaped by the principles of bioethics. Candidates for the first tier, subdivided into 3 categories, were chosen due to risk of mortality and risk of exposure, prioritizing those who would benefit the most in order to maximize the vaccine's utility. The tiers listed here, which I'm sure you all have memorized by now, 1A, healthcare personnel and long-term care facility residents, 1B, people over 75 and non-healthcare frontline essential workers, and 1C, people over 75, people with high risk medical conditions, and essential workers not included in 1B. These are the tiers. These criteria explicitly prioritize the demographic at highest risk of dying, the elderly, particularly the elderly in congregate living facilities. But despite the extraordinarily disproportionate morbidity and mortality within communities of color, the tiers do not explicitly prioritize people in these communities. Rather, acknowledgement of healthcare disparities is included in the fine print on who counts as a 1B and a 1C essential worker, via caveats about the disproportionate impact on workers who belong to racial and ethnic minority groups. Thus, they are prioritized not as members of a vulnerable and hard-hit community, but via employment. In response to these allocation guidelines and the vaccines in general, Catholic responses went in 2 directions. The first, led by the Catholic Health Association, largely affirmed the CDC allocation guidelines, releasing principles to guide vaccine equity as early as July. CHA cites Catholic social principles, which is great, dignity of the human person, the common good, solidarity, subsidiarity, and the preferential option for vulnerable persons. Yet in the end, their guidelines differ little from those of the CDC and other secular agencies, emphasizing safety and efficacy, respect for human dignity, equitable distribution, and maximizing benefit. The other Catholic response has focused on the morality of the vaccines themselves. In fact, since the end of November, Catholic moral analysis and public commentary on the COVID-19 vaccines has focused almost exclusively on what has been dubbed the Catholic question, the possible connection between the vaccines and abortion. At issue is the fact that currently many biotech companies use cell lines derived from 2 fetuses aborted in 1964 and 1970 in the development or testing of vaccines and medical therapies. Some Catholics are concerned that to receive the vaccine might make them morally complicit in the practice of abortion, or may entail immoral cooperation with the evil of abortion. Although this question was essentially answered in 2005 by the Pontifical Academy for Life, this single question has dominated the discussion within Catholic bioethics and the Catholic press. Dozens of articles and statements analyzing the COVID-19 vaccines using the principle of moral cooperation have been published, confirming that the Pfizer and Moderna vaccines have almost no connection to the problematic cell lines. They also recognize that other vaccines do or may have a connection, but that the moral distance between them and the original abortions renders the vaccines morally acceptable, particularly given the lack of other options and the gravity of the pandemic. This position has been reaffirmed by the U.S. Conference of Catholic Bishops, the Pontifical Academy for Life, the Congregation for the Doctrine of the Faith, and yes, Pope Francis. Episcopal bodies across the globe have exhorted Catholics to receive the vaccine, agreeing with the Congregation for the Doctrine of the Faith, which states that, quote, from the ethical point of view, the morality of vaccination depends not only on the duty to protect one's own health, but also on the duty to pursue the common good. Yet, a few bishops and Catholic pundits continue to declaim the immorality of the vaccines, and the discussion of this question continues. While a few commentators have tried to move the needle, exhorting Catholics and all Americans to receive the vaccine as an act of charity and solidarity, The Catholic imagination seems untouched by almost any other question and continues to limit bioethics to questions about individual decision-making about particular technologies. But what if we moved the table? What different issues and questions might emerge if we were to view the COVID-19 vaccines from the peripheries, from the Englewood neighborhood in Chicago, or the favelas of Rio, or from a clinic in Zambia? What issues might Catholic bioethicists see, or what questions might they ask if they stood in one of those places? Well, they might see a continued blindness to questions of racial justice, right? So there's much debate about vaccines that use cell lines derived from aborted fetuses. But where's the conversation about Catholic complicity with racism when we use medical treatments derived from HeLa cell lines, taken in 1951 from the tissue of Henrietta Lacks, pictured here? Consistency would suggest that we would be complicit in this racism when we receive the polio vaccine, treatments for cancers, for blood disorders, and a myriad of other therapies that have used HeLa cell lines in their development. In addition, for all the rhetoric about commitment to addressing racial health disparities as 2020 unfolded, as vaccinations have rolled out, as we saw earlier, we are seeing the usual story. In Chicago last week, over half of vaccine recipients were white, where vaccination rates for Blacks and Latinos stood at about 16%, well below their demographics in these cities, trends that we are seeing across the United States. Some of this is due, not surprisingly, to what the New York Times refers to as a confluence of obstacles, including registration phone lines and websites that can take hours to navigate, lack of transportation or time off from jobs to get to appointments, as well as to excessively bureaucratic paperwork, which is difficult for the elderly and people of color to navigate. These obstacles could have been foreseen had those designing the systems moved the table and consulted with those who care for elderly family members or who live in economically disadvantaged communities. But these perspectives do not appear to have been taken into account. Other issues include white people monopolizing appointments in racial and ethnic communities, fragile vaccines being out of storage too long and expiring, and vaccine hesitancy among people of color due to deep-seated and reasonable mistrust of the health system, as well as from a remarkable number of healthcare workers. From a different periphery, we might see that by the end of 2021, the richer countries of the world are expected to vaccinate most or all of their citizens, as opposed to only 20% of people in resource-constrained countries. When the vaccines were approved in December, rich countries, with only 14% of the world's population, had reserved over half of the production of the 8 most promising vaccines. The US and the UK have purchased enough doses to vaccinate their populations 3 times over, and Canada 5 times over. The World Health Organization estimates that it might take 3 or 4 years, maybe 5, to achieve global herd immunity, given these politics as usual. So if Catholic bioethics is concerned about complicity, these global dynamics press us to ask hard questions about our own cooperation with skewed systems that continue to privilege the already privileged. And if Catholic bioethics is pro-life, we must consider that this vaccine apartheid is not only unjust, it is deadly. One study found that this stockpiling by wealthy countries will result in almost twice as many fatalities globally. Not only will people in poorer countries continue to become sick and die, and their economies continue to stall, deepening global health and economic inequities, but as has become frighteningly clear over the past month, as long as large parts of the world remain unvaccinated, the virus will continue to spread and mutate, potentially rendering our current vaccine effort useless. In other words, if the first world does not eradicate the virus from the rest of the world, new strains will arise, once again potentially ravaging us and our economies. Thus, ironically, if for no other reason than self-interest, we must work in solidarity for the global common good. Or, as we have recently heard, no one is safe until everyone is safe. When I gave a version of this talk a few weeks ago, my respondent asked, but don't countries have an obligation to vaccinate their own citizens first? And this is a really good question. It's a really important question. On the one hand, it's also how standard bioethics thinks. But importantly, the World Health Organization is already with Pope Francis trying to rethink our priorities. It has stated that its overarching goal is that the COVID-19 vaccines will, quote, contribute significantly to the equitable protection and promotion of human well-being among all peoples of the world. Its recommendations for just and equitable distribution of these vaccines are guided by 6 principles, which you can probably really barely read here. The principles of human well-being, equal respect, global equity, national equity, reciprocity, and legitimacy. Then they define them all there for you. But the way they define them and these principles themselves resonate deeply with the central principles of the Catholic tradition. The World Health Organization is implementing this moral framework through its COVAX initiative, coronavirus vaccine. As of December, COVAX had secured access to 2 billion doses of several promising vaccine candidates, meaning that, quote, all of COVAX's 190 participating and eligible economies will be able to access doses to protect vulnerable groups in the first half of 2021, which is good news, with a goal of providing 20% population coverage to 92 low and middle income countries by the end of the year. COVAX estimates that this should be sufficient to protect all tier 1 people across the globe. At least 67 countries are entirely reliant on COVAX for vaccine procurement. COVAX is very clear that its distribution will be driven by the principle of equality. It will first distribute the vaccine so that all countries are able to protect 3% of their population. This should be enough to protect people who are not just at high risk of being infected, but also pose a higher risk of transmitting COVID-19. People who are most likely to come into regular contact with the virus, like frontline healthcare workers and people working in congregate care settings. Only after all countries have first received enough doses to vaccinate 3% of their populations, then they will receive enough to vaccinate 20% of their populations, right? Only after everyone has received enough to vaccinate 20% of their populations will other countries be able to increase their coverage. So here we have an example of countries working together for the global common good, rather than just prioritizing self-interest in the name of vaccine nationalism. These principles transcend a crude utilitarianism and provide a framework not only for vanquishing the COVID-19 pandemic, but for building a post-pandemic approach to global health that lifts up the intrinsic worth of every human person and every national people. From the peripheries, it also becomes clear that moral wrangling over allocating scarce resources is in many ways a red herring. The real question is about the privileging of exorbitant profits over human lives. COVID-19 vaccines revive longstanding questions about patent laws and the monopolizing of the technology necessary to produce what the World Health Organization has rightly named a global public good. As a growing number of voices make clear, the scarcity of vaccines is not due primarily to the difficulties of upscaling production, but because many pharmaceutical companies are reluctant to share the methods for producing the vaccine with other manufacturers. In October, Moderna did announce that it would not enforce its patent rights related to the vaccine during the pandemic. Will other manufacturers follow suit? Patents are being protected, of course, to protect profits. But while companies like Pfizer might not have taken any public funds in 2020 specifically to develop its COVID-19 vaccine, the research behind all of these vaccines has been publicly funded for many years. In addition, public money will now be used to purchase the vaccines in huge quantities, funneling taxpayer money to a few pharma companies and generating for them billions in profits. Earlier this month, it was announced that Pfizer expects to make $4 billion in profit on $15 billion in gross revenues on its COVID-19 vaccines in 2021, making it, quote, the second highest revenue generating drug anywhere, anytime, in the middle of a global pandemic. But it's not only the pharmaceutical companies that are going to profit. Even before the vaccines were approved, stock prices for these firms shot up from anywhere from 60 to 1,000%, enriching investors. What moral questions are raised when a few profit from a system that denies low-cost, life-saving medications to most of the people in the world? Again, if Catholics are interested in questions of complicity and cooperation, what questions are raised for those of us who, via our retirement accounts or our college accounts, benefit financially from life-denying profits? We could also look at this privileging of profits over people from a different angle. The World Health Organization estimates that providing global vaccine coverage will cost about $35 billion. The UN further estimates that due to the economic impact of the pandemic, some 235 million people will need humanitarian assistance in 2021. That's a 40% increase from last year. To meet this record need, they are calling for an additional $35 billion in humanitarian aid for 2021. So together, the World Health Organization and the UN are looking for $70 billion in order to fund global vaccine coverage as well as immediate humanitarian aid. While these sound like big numbers, they are not unachievable sums. Indeed, while health systems were experiencing record financial losses, for the ultra-wealthy, the pandemic has been a financial windfall. The world's 5 centibillionaires, Jeff Bezos, Elon Musk, Bill Gates, Bernard Arnault, and Mark Zuckerberg, have together gained $260 billion since the pandemic began. That's the part in the light green here on this chart, right? That's how much they've made during the pandemic. Collectively, the 650 richest people in the world have increased their wealth during the pandemic by $1 trillion. Right? So 650 people, 1 year, $1 trillion. Were they to give just 3.5% of just that new excess pandemic generated wealth, the UN humanitarian aid goal would be met. Were they to tithe just once, just for 2021, the global humanitarian crisis could be averted and a critical mass of people could be vaccinated across the globe. And they would still have $900 billion of new wealth left. So many more issues could be discussed, but let me just raise 2 more, what we might call inappropriate technologies and the prioritization of healthcare workers in poor countries. On one level, the mRNA vaccines of Pfizer and Moderna are exciting new technologies, never used before in human beings, 90% effective. They're really great. Yet the dazzle of scientific breakthrough dims when viewed from the peripheries. For they need to be stored at seriously sub-zero temperatures, rendering them impossible to transport and store over 30% of the world. And what of vaccines that need multiple doses, given the logistical complexities in resource-poor settings? Heck, given the logistical complexities in the United States, right, which we have seen. Again, given that these technologies have been largely funded through public monies, what moral questions are raised when the biotech industry develops products that work for the haves while ignoring the practical realities of those who have not? And what might our vaccine allocation tiers look like from the peripheries on a global scale? Given the scarcity of trained healthcare personnel in resource-poor countries, Might not the preferential for the poor and commitments to health equity recommend that they be prioritized for vaccination, perhaps even ahead of non-healthcare workers in richer countries, like most of us? Physician and anthropologist Paul Farmer, who you will hear from in a couple of weeks, posits that the preferential option for the poor suggests that the poor are more deserving of good medical care than the rest of us. We might be reminded that while all healthcare workers are valuable, given the long-standing shortages in healthcare personnel in the global South, Africa, for example, has just 3% of the world's healthcare workers to care for 11% of the world's population, with 25% of the world's disease burden. It is imperative that healthcare workers in resource-poor contexts be prioritized and protected. These are Catholic questions, questions about medicine and medical technologies that cry out to be asked when we reorient ourselves from the peripheries. As I hope this overview has made clear, the moral dynamics at the root of many of these issues are not questions of autonomy or utility, but economics. The COVID-19 pandemic, and now the vaccines, exposes what Pope Francis describes as, quote, an economy that kills, a system that treats so many people as disposable, as cogs that can be thrown away. In Let Us Dream, he calls instead for, quote, an economy that sustains, protects, and regenerates, something he notably finds promoted by women economists, which should be of key importance to the people at St. Mary's College for sure. You can look this up in chapter 2 of Let Us Dream. From a Catholic perspective, the COVID-19 vaccines ought not be understood as a proprietary commodity for sure, or even simply as a global public good. Rather, they are a gift, a collective good from those who have for decades deployed God's gift of human reason in scientific pursuit, and those who have volunteered their bodies for clinical trials. Many of those bodies living notably along the peripheries. As such, the starting point for a Catholic perspective on the COVID-19 vaccines should not be one of scarcity or worse, moral hazard, but rather the principle of gratuity or gift. As both Pope Francis and Pope Emeritus Benedict XVI have argued, gratuity is the engine of an economy, a politics, and a culture that gives life. Gratuity opens up new avenues for freedom and creativity. At the global level, for example, it supports the practice of dose sharing, calling rich countries to share their vaccine stockpiles, especially their excesses, through the COVAX framework. It likewise calls the global community to fully fund the COVAX initiative, a goal which we have seen is certainly within reach. But the principle of gratuity also functions at the personal level. The effects of the pandemic on the elderly, communities of color, and the poor remind us of what Paul Farmer once wrote, that diseases themselves make a preferential option for the poor. Over the past year, the divides have widened. For instance, between those of us who can work from home and those who cannot. Or as a Wall Street Journal columnist put it, between people who get a paycheck deposited in their bank account no matter what, and those who don't. What is the call of gratuity in this situation? And how might it help us rethink vaccine distribution? Might charity and solidarity encourage those of us who can to move ourselves to the back of the line, ensuring that those who are at the greatest risk receive the vaccine before we do? As we close, let us return to our opening, a quote from Let Us Dream. We will not emerge from the COVID-19 pandemic the same. Will we emerge better? With a moral framework grounded not in arcane philosophical principles, but in the vibrant heart of our theological tradition, that of gift? The Pontifical Academy for Life asks, can this pandemic be the promise of a new beginning for the human community? Such a beginning, they note, will require, quote, a real conversion of minds and hearts. The perfect message for Lent. Equally, it will require a conversion of Catholic bioethics. Thank you.
Thank you very much for that, Dr. Lysaught. So much to think about there, and it's sparked quite a few questions in our chat. So I want to, without further ado, dive right into some of those. And there's some various themes both on the vaccine and on economics, and also on a particular American context here.
Yeah, let me stop sharing so that I can actually see you. So yes, there we go.
Sure. Great. So let's dive into the questions, because we have, like I said, we have quite a few and then different themes here. And maybe since you were just speaking about, you focused toward the end there often about vaccines and how recipients are chosen and how it's distributed. Let's start with one of the questions on that. So let me make sure I'm pulling up the right question here. So how would private companies fund their research if they don't make profits? Should only the government develop vaccines?
It's never an either or, right? Rule of bioethics, or ethics, number one. It's never, we're always posed with these either ors. It's always a dilemma. And the beauty of ethics is finding the third way. I mean, certainly all, businesses need to make a profit. Nobody has any problem with that. The research is pretty clear, however, that pharmaceutical companies like to claim that it takes, $1 billion or whatever to bring a drug to market, and it may, but most of that $1 billion is not actually their money. Most of the findings of pharma companies are built on research done at private universities, public universities, funded by our government, other governments over decades. In the case of the COVID vaccines, a lot of the research was funded by governments. Pfizer was very clear to not take any government money from international companies, but or international countries. But Moderna did, AstraZeneca did. Most of the vaccine development was funded by governments. So the question is more not shouldn't they make any money. The question is, on the rare occasion that we have a global pandemic, right? So we're in a different sort of situation. What might a moral and ethical company do, right? Might they reduce their profits? Sure. Might they share their patents for a certain period of time to ensure that everyone can, or that we can get herd immunity, right? And then resume their patent rights after a certain amount of time. That's what Moderna is planning on doing, right? Do circumstances make a difference? Yeah, I think that there can be morally relevant circumstances that ask people to voluntarily, right? You don't want to force them to do it. Ask them to voluntarily step up for the common good, because a lot of the profits that they already have, these billions that they've been making for a long time, have come from public money and public trust in the work of lots and lots and lots of people. So how are they woven into the international economy, both the regular economy, both the moral economy and the social economy? That's sort of the question I would pose back to them.
Thank you for that. We have another question about funding here, and you've talked about how it would be wonderful if the many billionaires' money were being distributed elsewhere, right? But the question posed by, I believe, one of our students is, how do we as Catholic citizens with no sway over that situation or with that amount of funds, how do we take part in distributing that profit elsewhere more fairly, more evenly, and more in line with the principles of Catholic social teaching?
Yeah. I mostly highlighted that because a lot of this economic stuff is invisible to us, right? We don't, mostly know that this is global financialization and whatnot, so it's important to know the landscape, right? So we have this rhetoric of scarcity, 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 and it's only scarce because we choose for it to be scarce, right? There's lots and lots of resources. There is an abundance of resources, but it's really skewed in terms of its distribution. And it used to be the case back when, for some people, America was great. We had like 90% taxes on corporations, right? We said you can make as much money as you want, but you're going to give a lot back to us, right? And that was the legal structure. And a lot of that money came back and went into our infrastructure and funded all kinds of common good and da 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 da. And then, of course, over the 1980s, mostly in 1990s, all those corporate, tax structures, now that very small pool of people, they make, they pay almost no taxes, right? We saw Jeff Bezos a couple of years ago, right? Paid no taxes for Amazon. So, what kind of sway do normal people have? In some ways, not much, except voting, right? Understanding the history of these issues, the complexity of these issues, that policies are made when we're not looking, and that they have these real impacts in the world. We can also go picket and ask them to donate their 10% just for the year, and solve some really big world problems. Use all those interfaces that they've created on social media to really shame them into sharing their money.
Absolutely, and I think we've seen some attempts at that, certainly. Social media being used as a tool, perhaps for good, perhaps not, but a fascinating way. Well, let's talk a little bit more. Another question about a question moving back more into this realm of the broader view of Catholic social teaching, and then maybe I'll give you a specific question about vaccines. But one of our watchers here, participants, is asking about kind of the difficult transitions that people have needed to make from an individual focused ethics to a community centered ethics. So when you're looking at where one person, individual, is a patient to where all people in the world are seen as patients in this. So he's asking, has mindset shift contributed to the pieces that you mentioned? And what's the next shift that needs to happen?
Right. So, if you go from the individual,
if you see a shift, a way of,
I think so. Well, like I said, I'm endlessly optimistic, so I sure hope that it's shifting. And if you try to upscale from 1 patient to 7 billion, right, you're going to get you're going to lose your mind. It's not going to work, and we'll give up. But I do think that it's hard to retool the Titanic during a pandemic. So I think what we've seen over the last 8 or 9 months is a changing consciousness among more people in secular bioethics than Catholic bioethics, I'm sorry to say, toward a realization that we need to move the table. So they see it, right? They don't have the ability in their toolbox to do that. So they need they're seeing that they need to reconfigure their toolbox. I think one of the things that we've seen with vaccine allocation is that they don't understand, right? So there was this concern about communities of color, for example, but since they hadn't shifted their method, they hadn't actually moved their table into these communities to listen and say, hey, can you help us put this vaccine distribution program together? It failed, right? Because we were still being this sort of unidirectional, we're going to take care of you. There's nothing to learn from you, right? We're not going to go over and listen and give power to people in other communities. So I think we're on the cusp. I think there's a realization. I think a lot more work is going to have to be done, first in secular bioethics, because I think they're ahead of us. But equally in Catholic bioethics, where there's much more resistance in Catholic bioethics to blurring the boundaries between Catholic social teaching, which is over here, and Catholic bioethics, which is over here, and never the twain shall talk to each other. I'm hopeful that this pandemic will have shaken up, public health and hospital systems. I think that in Catholic healthcare, there's also an understanding now of what they need to do to change it, right? So I think they're ahead of Catholic bioethics, but it's going to take a while to implement, right? To really figure it out and enact it. And there's a lot of social inertia and structures that are meant to obstruct that we have to take apart and get through before we're going to, really start to see changes. But I am optimistic.
There's another related question about that. You spoke about it mentioned the Catholic Health Association and how they're moving, but there are a lot of other church bodies out there who have teaching authority. So things like the USCCB, the Catholic bishops in the United States, as well as other, there are global bishops, there are bishops conferences all over the globe. So have you seen them address any of these issues that you've mentioned? Have they issued any new directives? What have you seen coming out of other church bodies, if anything?
Yeah, so again, Catholic Health Association, right? They're pushing some of this. This is, they're out in front of things, and they rolled out last week or the week before a big initiative on anti-racism in healthcare, right? So they recognize it, they want to name it, they want to figure out how to do it, they want to organize people to do it, and if you can get Catholic healthcare to do something, it's 15% of healthcare in the United States. It's a big group of people with a lot of resources, so they can make a real difference. Other American Episcopal bodies, I have not seen quite the same movement, shall we say. I think some of the other ones in some other countries, I would have to go double check, but I think perhaps the British bishops have been a little bit more forward. The Vatican actually is ahead of the U.S. Bishops' Conference, in my opinion, in speaking out about, trying to talk about vaccine nationalism, trying to talk about how the pandemic is affecting all of these vulnerable communities, how it interfaces with global health. So that's a good lead. Needs to trickle down.
Needs to trickle down. That's right. Education and formation, right? So I have some other specific questions about vaccines as well. Some of our students and former students are asking. I think we might have some nursing students on the Zoom as well here. So here's one. What would the ethical thing be to do if you know that vaccines are being thrown out or wasted?
Which we know, right? Well, and this also goes back to, this question about technologies, right? We're very excited that the Pfizer vaccine came out. I was, yay! And then you discover it has a off-the-shelf life of 6 hours. It's like, who came up with that? What group of engineers said, "Oh, that's a great design." So certainly, yeah, in some places, if you, this is where we need to have more, prudential judgment enter into public health spheres, I think. This concern for justice, which is really important, is creating this wastage. So is it in New York, right? If you give the vaccine to someone who's not in one of those 3 tiers, you can go to jail or be fined or whatever. Well, that seems a little excessive. But those parameters have been put up because we know that people are going to try to scam the system because of human nature. So, I do think that, the places where, people aren't showing up for appointments, sometimes for legitimate reasons, sometimes because, right, the system didn't figure out the logistics sufficiently. You have these extra doses of vaccine, they should not be going to waste. That's just really not a very good idea, right? Any ethical framework would say, yeah, no.
Yeah, and a related question about that is, given that you meant these vaccines that need to be kept at such super low temperatures, sub-zero temperatures. So is there a way to make the rapid distribution of a vaccine that needs to be kept so cold equitable, either in a US context, thinking about social location here and people who are on the margins within our own society, as well as looking globally?
Right. Yeah, I kind of, so a proposal, you could be really, cheeky. Well, sure, if Pfizer wants to create a vaccine that has to be stored at, I forget what, 90 below, then as they roll out, they need to bring with it the infrastructure needed to keep it cold enough, right? And that means wherever it goes, right? How about that for a proposal?
That I think that sounds like a great proposal.
Wouldn't get very far, but right, to think ahead about these sorts of issues.
Yeah, a lot of issues, questions around that too. You know, how are recipients of vaccines that are administered from missed appointments chosen? What would be a just and ethical way to do that? I think this has caused a lot of thought about issues like that.
Yeah, well, and I also think that part of it is what we're seeing is the effect of long-term failure to attend to these questions, right? We don't have a national public health infrastructure, really. And if we had, and as I think we're seeing in some other countries, the rollout would have been more just, more equitable, fairer, and you wouldn't be running into these, very situational sorts of dilemmas. So they're created by a system, right? And so the answer is fix the system. Now, of course, that doesn't help you at 2 o'clock when your vaccine's going to run out at 3. But longer term, the question is, right, let's move upstream and figure out where the source of the problem is. Otherwise, we're just going to keep having it with this issue, that issue. It's just going to manifest itself over and over again.
Yes, I appreciate you bringing up that system in your response. We have another question that really I think is looking at systemic injustice as well. So the lack of trust in the medical system on the part of many marginalized groups for good reason. It's an earned mistrust,
right?
And that's likely to, as we've probably seen, and many of us have seen in news reports, it's impacting vaccine distribution and vaccine reception, I should say, perhaps. We have a question by someone who says, as someone who's been discriminated against by the medical community, I'm interested in how bioethicists and the medical field as a whole are grappling with the issue of earned mistrust.
Feeling guilty. Not grappling very well. No, it's a real thing. I think, again, we're at the beginning to address this question. It's not going to solve it. It's not going to make it go away. This semester, I'm teaching a class, a doctoral seminar on theology, race, and Catholic healthcare, right? So every week we're reading yet another dimension of why this mistrust exists. And it's just horrific, right? I mean, this week we read Harriet Washington's Medical Apartheid, right? Which just focuses on racism in medical research and experimentation. And it is horrifying. It's an example after example after example after example over 150 years, and it's still going on, right? A lot of these studies she's talking about are in the 2000s, and that's just research, right? That's not OBGYN, that's not psychiatry, that's not every single area of medicine has its own history. So it's a long, dark, complicated, multi-leveled history that has generated this mistrust. That's a completely reasonable mistrust. How do you overcome that? One of my students actually wants to write about that for her final paper, right? She's a mission leader of a Catholic health system. She wants to talk about how can we rebuild trust in my community, right? So we'll see what her answer is in May, at the end of the semester. But I think that it's going to involve a lot of systems. You can't undo past harms, right? So you can only figure out how can we move forward with the people we have, with the communities we have, and partly a truth and reconciliation process of sorts, right? Trust is related to truth. So how do health systems, physician groups, whoever practices medicine, what is their relationship with the community, right? How often do they go into their community, not with an agenda, but just to go tell me the stories of your family and healthcare in this place over the last 30 years? What has it been? A lot of them don't even know, right? These systems don't even know, hospitals don't even know. Ask them, what would be required to start to rebuild your trust? What are some practices? What are some, not some attitudes, but some actual concrete activities? What would it take? Right. And to start building from the other side, practices of reconciliation based on truth. But people don't want to hear these stories. They don't want to go get that truth. But I think that's the kind of thing it would take. And you know, a lot of this stuff, if you read Harriet Washington's book or any of these other, this stuff was funded by the US government. You know, so there needs to be maybe some sort of participation on the part of the NIH and NSF and other funding agencies, you know, who approved these studies, never batted an eye. The IRBs failed. So yeah, that'll work. That's a whole nother lecture.
And I think we have
I think you'll be, so come back to Corey Mitchell's lecture and he will have chapter and verse on how to solve that problem. That's what he does for a living.
Oh, wonderful. Well, we'll look forward to that. I think that's a great way to end this here. I love what you said about practices of reconciliation based on truth and really going out of our own comfort zone to listen to people's stories who have been injured, hurt, oppressed, abused, and incorporating that into, for us Christians, into the Christian story and responding appropriately. So what better thing to do for Lent, right?
And if there's any questions you didn't get
we
to,
are
I would be happy to try to talk to people by email or whatever. So that would be fine.
Wonderful. And we will post we'll post a video of this on our Facebook page, the Center for Spirituality's Facebook page. You can message us there, email as well, and we can pass things along, cfs@stmarys.edu. We're very pleased to have been able to spend the past hour or so engaging with our esteemed presenter. And for all of you who have attended with our first event in the Center for Spirituality Spring Lecture Series, Spirituality, Ethics, and Healthcare, thank you very much to Dr. Therese Lysaught for your excellent presentation and really engaging with these questions so deeply.
Oh, they're great.
Thank you to the staff of St. Mary's College. They were excellent, yes. Thank you to the staff of St. Mary's College campus and community events, integrated marketing and communications, and all of the others who've worked behind the scenes for their assistance with the logistics, and also to the donors who make this Endowed Lecture Series possible. We hope that you'll join us for our second event featuring Dr. Paul Farmer on March 4th. Details are at stmarys.edu/events. Good night, everyone.
Thank you very much.